An associate professor. Okay, recording in progress. Okay. Dr. Nuño is an associate professor in the Department of Biostatistics at UC Davis, UC San Diego, UC Davis, sorry. We have so many campuses, so UC Davis. Just want to make sure. And she is interested in the application of statistics and applied mathematics to solve public health challenges, reduce health disparities, and improve patient health outcomes. Her expertise ties at the interface of biostatistics, mathematical modeling, epidemiology, and public health. She is an author of more than 130 peer-reviewed publications, and areas of expertise include statistical methods for multivariable and cluster longitudinal study design, observational studies, and big data analytics. She's done quite a bit of like COVID-19 research on earlier studies on influenza pandemics, strain dynamics, and cross-immunity. And she developed models assessing pandemic's impact on nursing home residents, identifying key prevention opportunities. There's a bunch more, but I want to respect our time and I want to give Dr. Nuno like enough time to share her work. And as always, I'm hoping that we have some time at the end for you all to ask her questions. So I'm going to turn the floor over to Miriam. Welcome.
Thank you so much for the great introduction and thank you for inviting me to present. Can you all see my screen here?
I think it's loading. Hang on one second. Start a screenshot. Okay, there you go. Yes, perfect.
Okay, thank you. So, I'll be talking about, I guess, my background in math and high interest in public health, and I'll try to make a point of, trying to think about impact with my research. And because of the global nature of the people here today, I have added some examples of where I think, even though the work that I've done is, locally, nationally within the U.S., that it could easily be expanded globally. And so just, I'll talk a little bit about myself and my academic path, my collaborations, and I guess, just giving this talk gives me an opportunity to reflect that a lot of my collaborations have really focused on, collaborations with folks that really, highlight the importance of diversity and health equity in research. I'll talk about a couple examples of my recent research projects, and then, think about future directions. For the future directions, I'll just talk about that. And so just a little bit about myself. I was born in Guadalajara, Mexico, which is, here, sort of north and east of Mexico City. I came to the U.S. when I was 14. I'm one of six siblings. And, I think just coming to the U.S. and not having English as a language, I think math became a language, and I really loved math when I came here, so I stuck with it. And here's my family. I have two sons, Franco and Tony, and my husband James. So here's my path. The point with this figure is that my path has been really windy. Why? Not straight path. I studied at UC Riverside in pure mathematics, and then I went to Claremont Graduate University to do applied math, and then I ended up doing my PhD in biological statistics in Cornell University. And through my experience at Cornell with my advisor, we got to spend some time in Los Alamos National Laboratory in North Carolina. And then I went on to do a postdoc at Harvard School of Public Health, which is where I got the bug of really getting into public health with my work. And then I went back to UCLA for a postdoc, and then eventually got a job at Cedars-Sinai as a senior statistician working with neurologists and brain surgeons, which was super fun. And then I found my home at Davis. So, I think the point with this slide is that, I really have tried to find the place where I'm really, really happy and love what I do. And I guess it took me a while, but I'm really excited to say that I love what I do today. And so in terms of who I am, at the center of myself is obviously, I'm a mathematician and then statistics. And as I mentioned, throughout my career, health disparities has really become something very important. I've had this exposures with public health schools and really love applying my work in that context. I really, when I talk to people, and if you talk about data, you will notice that my eyes just get really sparkly because I just love data and what stories you can tell with data. I also love infectious diseases. My PhD dissertation was on pandemics of all things, and so anyway, it's been a fun ride. Um, this slide I recently put it together as I sort of think about myself and finding myself in the greater, universe. And one of the things that I think of in terms of myself is, I am sort of part of, a process that, continues to evolve as I, come across different people, different collaborators. As a statistician, you get to play in backyards of all people, people that do brain surgery, they do, surgical outcomes research, and so I really am blessed to be able to be exposed to many areas. But I guess one of the things that I would say that I have found for myself that I would, if anything that you can take from this lecture is, me finding my strengths, my areas of growth, my values, and what motivates me, and having that be the core of how I do my research. I feel like we all talk about, eventually you'll be worried a lot about, getting grants and getting funding. And I feel like for me, finding these four things has really uh, kept me grounded. And then, and then success comes along the way. Um, I think that one critical piece that I would also mention, and I'm sure you all have experienced this by now, is that the critical roles that mentors play throughout your pipeline and process. And so, this is something that I've learned, and I feel like a lot of my success has been because I've met wonderful people along the way. And as I mentioned, here to the left, we have Keith Black, which is like a world-renowned brain surgeon from Cedars-Sinai Medical Center, Dr. Patel, Dr. Piantedosi, which is the top-notch, clinical trial statistician, and Dr. Bellin at UC, LA, and Dr. Piantadosi from Harvard. And so, yeah, I think I'm super blessed to have had wonderful mentors, and obviously my PhD advisor and my parents are also, key mentors since I can remember. Um, so we have a research team at UC Davis, and I think our focus, has been a lot with infectious diseases. I mentioned that I have experience in coming through hospitals and neurology and so neurosurgery. So I really love looking at health research outcomes in terms of patient quality of care. And then because of my current department, there's a really big Center for Climate Change, and so we've collaborated with them a lot on climate change impacts on health and outcomes. Here is just a small list of some of my collaborators, but the main point that I want to share with this slide is that my collaborators are really, really diverse. So we have Center for Reducing Health Disparities, which is led by Sergio Aguilar Garciola, who, when I came to David, was my like Kim Kardashian. I was like, I want to meet that guy and I want to work with that guy. And so I think I have been really blessed to through COVID being able to work with Sergio here, and then I have some collaborations with the wastewater surveillance and civil engineers and infectious disease folks, which I'll talk about some of the projects that we're doing on wastewater surveillance. We've worked on the impact of wildfires using Twitter data. So we have some colleagues in the mathematics and veterinary school. As I mentioned, I also work with surgeons and cardiovascular doctors. And then we work with UCLA on this project that is called Together for Wellness, or Juntos por Nuestro Bienestar, which is trying to improve mental well-being of Californians. And so anyway, I really also want to give a shout out to my mentees. I really, in addition to research, really recognize the importance of mentorship. So I try to do as much mentoring as I can. And so let's just, walk into, some specific examples of research that we did. So, not to belabor COVID-19, which I think all of us probably are done hearing about, but I guess the point with this project here was, that, as I mentioned, I finished my PhD dissertation in 2005. And one of the dissertation projects that I did was, thinking about if we had a pandemic, what would it look like to protect residents of nursing homes? And we did this work, as I mentioned, back in 2005. And, we did a really beautiful job. We got to publish a PNAS. And then, fast forward to the present of COVID, people were asking, could you get involved in that again? And I initially was like, well, no, there's too many modelers. They don't need someone else. But because of this work, we did get involved. And so, this work in terms of nursing homes was specifically trying to figure out, could testing and vaccination reduce the impact of COVID-19 in the nursing home? And so we did a, agent-based approach to model the dynamics of COVID-19 in nursing homes in Los Angeles. Um, and, pretty much the findings are that in order for you to be able to, reduce the impact of nursing homes from COVID, we really need to reach, nearly 80% or higher of isolation of asymptomatic cases. And so I can walk you through what we did and why this was important. So I don't know if many of you recall, but even though the elderly population in the U.S. is less than 1%, 7% of all cases in the U.S. Of COVID cases were nursing home cases, and then 41% of all deaths in the U.S. were deaths related to nursing home members. And so we thought that it was really, really critical to look at this. And so, as I mentioned, this is the work that we published back in 2005, 2008. And so the model is this. It's kind of with modeling, you start really simple and then you extend based on how much data you have. So the idea with these models is that you have the world of the nursing homes, and then within the nursing homes, you have residents, you have staff, you have people that visit, and then each individual is categorized as either being susceptible, you're exposed, you're infected. If you're infected, you have the option of, with some rates to become hospitalized, to be recovered, or to succumb to death. And then you have also asymptomatic individuals. And then you also can imagine you have members of the community, which are staff and visitors, which come in and out of the nursing home. And those individuals are also categorized as either being susceptible, exposed, and so on. And the idea is that you start your simulation, and then you, by this time, we had a really good sense of the parameters that we should assume for this simulation. And then I was actually really lucky to connect with a lot of nursing homes across California to kind of figure out, these rates and these parameters. We were actually, it was kind of excited to do sort of, like interviewing of some, people that were running these facilities through the pandemic and really learn, the realities that they were facing. And so what we will do with these simulations that I will show you in the results is that we wanted to, think about, can we identify or exclude potential residents or staff or visitors? Can we implement protective, equipment, which we had in like masks? And then we also wanted to monitor staff and visitors as they were coming into the facility for temperatures. And then one thing that we found is, typically nurses or staff have specific schedules. And so we wanted to say what kind of schedules, working schedules, would be ideal to minimize the introduction of infections. And then eventually, as we all learn, we needed to restrict visitation because that became a really major problem. And so I know this is a very busy slide, but I think what I want to show you is that with these kinds of models, you can look at different scenarios. So the first column here, which we have the baseline scenario, in that scenario, we see, okay, we assume that there's no isolation being implemented, that there's no implementations of PPEs, that there's no limitations on visitation, that there's no changes in staff working schedules. And then as we move from the baseline scenario to say category 1, 2, category 3, 4, and then category 5, what we've done is we've incorporated more restrictions. And so the results that I'm going to show you are really category 5. The reason being is that things were really bad in these nursing homes that we really needed to put in place every possible intervention that we could do to really try to make an impact. And so the category 5 that you will see here is looking in some cases at complete isolation, implementation of PPEs to the greatest degree that we could. And then we wanted to do the limitations of the monitoring of temperature to the greatest degree that we could also do. And then what we found was that, schedules for staff and nurses that were 4 days on, 4 days off was the ideal setting for, improving. And then in terms of visitation, we said absolutely no visitations because, things got pretty bad. And so here's what we are able to conclude from our simulations. So on the x-axis, we have the basic reproductive number, which is by definition the average number of infections that a single infected individual will generate in a fully susceptible population. And so for COVID, we saw that the R naught was somewhere between 2 and 3.2, at least initially. And then this number was much bigger for the different waves that we saw later in the pandemic. And so what we can see here, the point that we're trying to make is that if you look at the attack rate and the parameter that we're varying is isolation of asymptomatic individuals, that you see that really in order to really reduce the attack rate, you have to isolate beyond 80%, right? So, almost, a perfect, isolation of individuals that are asymptomatic, which is super challenging. There's a couple, more things that we did. So in this figure on the left, you have 2 columns. We're looking at, are we able to reduce the peak of cases when we have no isolation in this scenario versus having 50% isolation? And so what I want to point to attention is the reduction in peak cases. So the scale with no isolation goes from between 0 to 7. So we're able to reduce the peak cases by 7, 5. But if we incorporate isolation, we're able to reduce that to like 15 to 20, which is a pretty significant reduction. We also wanted to look at what happens if we reduce the peak time, because what we found is the idea was not to say that you can prevent infections, but really to delay peak of cases. And so what we find that when you have no isolation, the average peak time delays is somewhere between 6 and 14. But if we incorporate isolation, we're able to, delay that by, somewhere between 15 and 20, depending on whether you have the category 1 or the category 5. And so, this allows us to, in summary, what we found from this study was that community outbreaks were almost always followed by an outbreak in a facility. And even if we have very stringent non-pharmaceutical interventions, you really are unlikely to prevent the introduction altogether. And this is actually something that we found when I was interviewing a lot of nursing homes, that we found that if there is community spread, it will get into the nursing home regardless. But you can delay when it gets in. And so what we were trying to do is, at the peak of the pandemic, the hospitals were overrun. And so we wanted to at least delay those nursing homes from reaching that point. And one of the nursing homes that we actually interviewed, it took them a long time to see an introduction in their facility. They were one of the best ones that we were able to look at in terms of what they have, implemented in terms of restriction. But eventually it did get in. And so, this, we say that even if, the most restrictive interventions, we did not see a reduction in mortality or the attack rate unless you implemented really high levels of, isolation of asymptomatics. And, we did see some significant reductions in outbreak peaks in the average peak time. And I think that, just buying people a little bit more time can be very useful. And so I guess the key finding that I wanted to highlight in terms of like how is our work relevant globally? And so interestingly enough, the problem of nursing home death was not just specific to the US. Those of you that were connected, to the news, which is all of us, uh, we saw that this was true everywhere around the world. I think Spain, Chile, Norway, everyone had this problem. And so in a way, the lessons that we've learned locally, I think that there is potential for generalizability of this work to, around the globe. Um, and so in terms of like quick, global implications and opportunities, I think that what we've learned is that, protecting high risk population across countries should be a major priority. One of the things that I learned from this research was, the cultural differences in how we treat the elderly. So like I know in Mexico, we have less of a tendency to have nursing homes, and usually the elderly live in our homes. I think in the US, it's a more common thing that maybe elderly live in nursing homes than in other places around the globe. Um, and, in terms of like, other opportunities, I think that there's an opportunity to enhance our policies for long-term care facilities. We need to prioritize investments in the infrastructure, the staffing, the technologies that these, facilities may have to really improve, surveillance and vaccine delivery, real time. And in terms of like other ways to improve, I think that, it would be great to, come up with some collaborations globally to share data, to share best practices, to share innovations, to really, mitigate the impact of COVID. And not just COVID, but I think that there's other pathogens that are concerning, on a real time basis. Um, so I'll talk about a second project that was really motivated on on June 2021. California had to come to the conclusion that we're all going to open the economy and we're going to go back to regular business as usual. And I think we were all done with the pandemic and we were like, yes, let's go back to normal dynamics and stuff. And so one of the questions that we had, because our team had been monitoring vaccination uptake across California, was that their uptake in California was not really equitable across all communities. And so we thought, are we ready for these? And so this is sort of the motivation for our work. We wanted to address the adequacy and efficiency of vaccine uptake, with the possibility, that if we open too early, that we might have a resurgence and specific, vulnerable communities. And so, at least we said, can we think about this thoughtfully and can we have a model that might guide us through that process? And so we did a model that looked, a very simple model of to say, you always start super, super simple, based on, the data that we had available. And so this is, again, a model that looks at, the population that's, susceptible, exposed, people that are vaccinated with the first dose, with the second dose, people that are recovered, people that die, people that are underdiagnosed, because we know that there's going to be people that are underdiagnosed. And so with that model, this is what we came up with in terms of conclusions. For this kind of approach, we use the Bayesian sequential forecasting framework because we wanted to be able to have a prediction model that gets updated as new data comes in. And so what we can see in the top left is here's the data in terms of confirmed cases. And this is, data that we started looking at December 6, 2021. And so in terms of like what we see here is we have the median projection of cases in terms of confirmed cases. And then here below we have, what would it look like if we want to use this data to project forward? And so, here is the data. These block boxes here is the actual data. And then the red line is the median of those confirmed cases. And then we want to say, given this data that we have here up to May 15th, what would it look like in terms of confirmed cases and confirmed deaths across, California? And then we also did some different scenarios for different counties just to get a sense of like, are we there yet in terms of, are we going to see a surge? or are we expecting things to stay steady? And so I think that this light here is what shows in terms of the motivation that when you look at what a goal was, and in terms in California, we had a goal of vaccination of 75% of at least one dose, and so this is what the uptake of that looks like. And so what I want to show you is that even though as a state we had a goal of 75, when you look more regionally, and I guess, because we are in Yolo County, Sacramento nearby, this is what the data look like in terms of more locally. And you can say that, although overall as California we had a goal of 75%, you can see that there's certainly some counties and regions, specific zip codes that are way below, 75. And so, what we did was to monitor those regions more locally, and ensure that, if we open the economy, that there wouldn't be an increase in cases. And so what we did strategically was to, use some of the mobile clinics that we had to bring vaccination to these areas of low vaccination. Okay. And so there's this last project that I want to talk about, which I think is, the one project that we continue to be very, very active with and really, really excited about. This is looking at the optimization of the spatial distribution of wastewater-based epidemiology to advance health equity. So California, the U.S., and really across the world, throughout the pandemic, people, really did advances to monitor wastewater surveillance, to monitor different pathogens. Specifically for the pandemic, it was COVID-19. And, I became kind of in love with this data because I'm like, this is data that we in theory think is garbage, but actually it's like amazing. And so we have continued to do work on that. But, one of the things that we saw when you look at the monitor of wastewater across California is that the locations of monitoring are really not, as in my mind, equitable across California. And so we thought, could we think of ways to have the collection or surveillance in a way that is protecting, people more equitable, and especially those areas that we saw throughout the pandemic that experienced high infections and deaths. And so this is the idea with this project, that we wanted to say, if we did optimize the spatial distribution of this wastewater surveillance in a way that is more inclusive of the population, more representative of disadvantaged groups, would that be a better approach? And so this is kind of what we did with this project. And because I don't know how many of you know about, wastewater surveillance, and I'm also not an expert on this, but I know that, there is the wastewater. We all, brush our teeth and dispose of that water at the community level, and then it gets processed. Their samples are taken, people extract RNA, and then we're given that information. Now, what's really amazing about this is that, doing the wastewater approach really beats the testing, because as we found, with testing, it depends on how much testing you're doing to really get a good estimate of the infection spread in the community. And with wastewater, you really have more information. And so a lot of the work that we have done is, try to understand how much, the benefits of using wastewater surveillance really. This figure here, provides a really, really nice example of, with wastewater surveillance, you get about 12 to 13 days information before testing. And so we're getting, almost 2 weeks in advance data on peaks or infection in the community, whereas testing, often takes a lot more time. And then in terms of hospitalizations, we get about 26 to 27 days. And so it also allows us to, really prepare or plan or strategize, hospital resources using wastewater. And so this is the data that we will be using for these results here. So on the left, we have the current locations that are monitoring wastewater. And so one of the things that you can see is that there's definitely, a high, so there's two things presented in this figure. First is the location of wastewater, and second is the blue coloring, which corresponds to the social vulnerability index in California. And so the regions with darker blue are the regions with more that are more vulnerable according to the social vulnerability index. And so what we can see is that, here we have this Bay Area where we have, very light blue, which in terms of the social vulnerability index is low vulnerability. So we have quite a bit of monitoring. And then we have regions, in the Central Valley, which we know that there were regions that were really impacted. We have Imperial County that is hardly any monitoring going on, which is also really high blue. And so with that, if I could redo this, is how would I reframe this, surveillance? And then here to the right, we have the number of treatment plants that we are going to be using for looking at the similarity, which, I will talk about. But so here's the model that we are looking at here. It's a function, a little, this is the most mathematics you're going to see. So it's just a big equation, but really what we're looking at is an equation that takes into account the population that is being served by the plant, the population density that is being, associated with the plant. This one should be the dissimilarity. And then we have social vulnerability index. This is a distribution. And so the idea is that, we have many factors that we're taking into account, and we have ways for each of the factors. And we can say, okay, what would it look like if I wanted to, regenerate a mapping of where the surveillance site should be if I prioritize, say, on vulnerability, or if I prioritize on the population that is being served. And so here are some scenarios that we ran. First, you can see that for scenario one, we're saying, okay, what if in scenario A, I'm prioritizing social vulnerability index, and then these are the weights that I assign for the rest. So these are the weights for each of those factors, and the higher the weights, the higher the priority that I'm placing on that specific factor. So this is playing a big priority on social vulnerability. This is placing a big priority on population served. And then this is saying, let's just go all equal across, prioritize things equally. And so this is the first scenario that we will see. And then the second scenario we're going to look at is looking at the similarity of the signals. So ideally what you want to say is, I have, say, 50, plants. If I have 10 plants very close, let's say in LA, 10 plants, if all those 10 plants tend to give me a very similar signal, do I need 10 plants, or do I just need 5 or 2 or 3, right? If how similar they are, they're giving me the same information in some way. And so these are the results that we obtain. So in the baseline scenario is, how do things look like without anything? This is just the baseline. We have 84 plants in California. Scenario A is, what would it look like if, because we are downscaling, right? One of the things with wastewater surveillance is that even though it's, data that is easy for me to analyze, it's very expensive to keep up this surveillance, and it's also a lot of work for the community. I mean, the people that are collecting the data. So one thing that we have seen from the CDC is that we are going to be downscaling on the surveillance of this. And so this scenario says, what if, someone came to me and said, Miriam, I'm downscaling my plants by 40% from this, and if I prioritize social vulnerability index, this is what the distribution will look like in figure A. If I prioritize on the population served, this is what the distribution will look like. And if I have an approach that prioritizes all things equally, these are the plants that I should include if I'm reducing by 40%. And this is just to give you a sense of what do I mean by dissimilarity. So these are our plants, and then the regions that are darkest in blue are the regions that are most similar to each other. So then in theory, the different locations are very similar to each other, that they can borrow information and we don't have to monitor them all together. And then this is the scenario where we're looking at specifically dissimilarity. So in baseline, we see that we have, only 19 plants that we're considering. And then for figure A is what would it look like if I prioritize dissimilarity. And then if I say equal factors, this is what it would look like in B. And then if I give higher weights to vulnerability and signal dissimilarity, then this is what this will look like. And so I think, in terms of a summary for these, my so my take homes are that we can promote health equity through surveillance optimization based on this approach that we have presented. We think that this approach is scalable and adaptable, that could be used in theoretical sense for the whole US and not just California. It could also be used worldwide for different countries that are monitoring wastewater. And I really think that, in terms of what I've come across in my career, so far for me, it seems like a really critical tool that could be used in public health to monitor, health trends. People have used it to monitor drug use, and that's sort of something that, has to be thought about in terms of ethical. But, and clearly, it could be used in terms of, capturing the emerging threats, not just for COVID, but like norovirus, RSV, influenza, things that we experience quite a bit here in the U.S. And this has been used. Wastewater has been used across the globe. People are really interested in looking at resistance, bacterial resistance, antimicrobial resistance across the world, and so this is a really great example of how this data is already being used globally. And I think that I'll stop there. And thank you all for your time today. And I'm excited to hear about any questions that you may have.
All right. Wow, that was amazing. You, excuse me. You spent the time to highlight your amazing work, and you did in such an efficient manner. It was super informative and really exciting. So, um, I'm going to invite our trainees to, you can either type your question in the chat, or you can, if you're comfortable, you can unmute and um, ask away. Um, yeah, so thank you so much. This is
Thank you.
awesome.
Thank
Any questions for Dr. Nuno? I wonder, is some of you doing work on wastewater-based epidemiology? I don't remember. Mariah, are you doing that work or somebody else? I forget.
Not me. I think it might have been Cheyenne. I'm not sure if she's
Okay, I
here.
don't see her on the screen today.
you.
So I can start the conversation, I guess. I was really Um, the slide in the beginning where you showed like your career path and how you approach your work and the Venn diagram of your strength and your areas for improvement and your motivation and values.
Mm-hmm.
I thought that was really awesome and it was very eye-opening in terms of, how you approach your work. Um, so I guess in terms of promoting self-awareness, like how do you go about practicing this on a
Yeah.
regular basis?
Well, that's a great question because the way, to be honest with you all, the way has been more is like I repeat it and then eventually like it sinks, because I do, I think something that is kind of amazing about the fellows that are here and probably, everyone is, you know, me as a person that, was, doing math, sitting in places like when I was at Cedar, sitting in these brain tumor boards where there's, these top-notch surgeons, radiologists, oncologists, and me being like the only person that is, with the statistics hat. I
Mhm.
remember feeling like, oh man, I don't quite belong here. What am I doing here? But I felt like this is so cool. And I think that what was kind of interesting when I was in those rooms, that eventually one of the things that I kept thinking is, people are making decisions about what do we do about these complicated cases, right? Do we
Mm,
operate? Do we
mm,
like do radiation? Do we do chemotherapy? And I always kept thinking to myself, like, shouldn't there be an algorithm that helps them make that
mm,
decision, right?
mm,
Not to mention that, obviously they're experts, but I did learn that, eventually what we have, the strengths that we have, actually, when you come into the settings, you kind of add to the setting, but initially you can think, I don't fit in this setting. So I
mm,
think it took me a while to realize that actually the things that I'm different by are the things that I can contribute more by, And
mm,
so instead of thinking it as is it an area of growth or a strength, and feeling comfortable with saying I can contribute,
mm.
and so I think that's something that it took me a while for sure, you know.
Yeah,
Um,
that's amazing.
and there's a question here that says, how often do you get to utilize or influence policy with such great findings? So I feel like this is where I'm stuck in a way.
Mm, mm,
I mentioned to you that back in 2005, we wrote those cool papers. We even, worked with Tom Riker, and actually Tom Riker developed a video that would teach nursing homes about how do you actually do this? Like, what does it look like on a typical day? Show up, you clean your hands, you do this, right? And he created a video, and it was amazing. But then like 20 almost years went by, and then we got hit with COVID, and I thought, what
mm,
did we learn? We didn't
mm,
learn anything, right? Because you have all these beautiful papers that in theory like never really make it to like changing policy or changing
mm,
structures. And so I think this is sort of one of my hangups, that I'm like, how do I actually get from here to like policy? And so
mm,
I think definitely I haven't been so quite successful with that, but I think I am trying more these days when I feel more in a way empowered to like,
mm,
now I'm tenure, so like, I have a little more flexibility. But one of the works that we're doing most recently is we're working directly with community partners.
mm,
And so now I'm trying to ask those questions. Sure, this grant is about, improving XYZ. Is it actually improving XYZ? Or is it just generating a lot more research evidence, and then is it not really translating into changing people? And so with the collaboration that I have with community partners, we actually recently had a town hall in Fresno where we brought the findings from the survey that I helped them support and analyze, and we brought the voices of people that say, hey, we need more affordable housing, we need more safe transportation, we need a park that hasn't been built, like a surveying park that is broken for like years. And so I was actually for the first time in my life present with politicians and asking these questions of them and saying, look, you need to be able to change these
yeah,
things. And what I found was that they have a very different way of thinking. Like politicians have a very like almost like a very narrow lens to do their work, and they're so different from like what the community is saying. And so
mm,
somehow I found myself in the middle, like understanding their points, and then the community, and we just need to narrow that big gap. And so I do feel like that's kind of moving into like a different area that is not like statistics or math, is more like social conscience and advocacy. But I feel like in a way like we all kind of have to have a little bit of that, so that we're not just we're not just the researcher, or we're not just the politician,
yeah.
or we're just not the community partner. We're like a little bit of everything to understand it and make change. So I guess I'll report back in a couple 20 years to see if I feel like I'm making a change in the way. But I feel like that's a wonderful question because you know I mean no one ever teaches that as a mathematician, statistician, you could have that power to like change things. And so obviously having collaborators that public health policy are critical, but it's challenging, and I feel like we get too comfortable in our own silos. And so
Mm,
I have a feeling that the people here are not like that, because I saw the profiles of everyone and the amazing things that they're doing, and they're really trying to change things in a meaningful way. So this is exciting.
Yeah. Well, thank you so much. I have a feeling I don't have to wait 20 years to see how your work will have significant policy impact. So I really appreciate it. And I think you touch upon a lot of important things in terms of how we provide meaningful and effective messaging, depending on who the audience is, and also like this idea of elevating like team science approach, including community folks as well as, policymakers and how they view the issue is very different. But I think you bring a very different and unique perspective that can bridge this, big gap that we have. So. Yeah, really, really exciting. And yeah, I mean, I think the whole, the one of the silver linings, I guess, about the COVID-19 pandemic is that like, I'm trained as an epidemiologist, and before the COVID-19, like not that many people knew like what epidemiology was. And now I think it's at least in the public like knowledge in terms of what epidemiology is. And I think it's an opportunity for us to really think about, how we make like societal impact on, the knowledge that we have and translating into our community. So yeah,
Hmm.
so
Yeah,
really.
it's a great feat.
Okay, that's great. So we're doing well on time. We still have a few more minutes. Any other reflections, questions? Anybody else, specific questions about water-based epidemiology or,
I guess one question that I would have for, the people here is, you know, as a researcher, are there any specific uh, um, recommendations of how to actually influence meaningful change? Because, in my talk at the very beginning, I say in that I had a focus on impact, and I'm just curious about like any of you guys have had experiences where you actually, are doing something very specific that you feel that is really, influencing policy, because I feel like that is sort of one of, or at least, getting close to influence policy, or like if that's one of the, I guess, Peter, you asked that question. I was wondering, if anyone has had, more success with that.
I have a small amount of insight, not necessarily related to my research life now, but prior to completing my PhD, I worked for a nonprofit that did environmental health hazard advocacy. And so, like, my concern in listening to your presentation, I think all of our concern is how where funding is going to go with this new administration
mm,
in your area. And I don't think any of us have an answer, but I think we're all afraid. But I think in terms of changing policy, our the scientists involved in EIA, they were focused on things like groundwater, asbestos, lead, and it always seemed like when we were pushing to make change, partnering with other advocacy organizations that already had the ear
Mm-hmm.
of policymakers was a big deal. Our director got put in front of congressional committees with our research, and that usually had the biggest impact, educating the public about things like asbestos and the fact that it wasn't banned until earlier this year, which people didn't know, and then combining that with the science that our organization was bringing to these public advocacy organizations and getting us in front of the policymakers. So I think it's collaboration is the key. It's the name of the game.
Yeah, and I guess one thing that I've learned in my limited experience with collaborating with communities actually is such a, desert of information that it's so we've given several workshops in the Central Valley, and often when I give these, discussions, people don't realize they're in counties with the highest incidence for these and the highest
mm,
incidence for that, and and for me, that's sort of just one way for me to say this is a great opportunity here. But I've been so shocked to hear the communities often are not aware of all the, exposures and outcomes that they face. And so I feel like many of them, like, they often say, like, we don't know. And when there's no communication with our, our mayors and our policy, officials. So I feel like even just bringing in information in a way that, people can, take in. So one of the things that we're trying to do is we work with several, community organizations, and we're trying to help them build these dashboards to get a finger on the pulse in terms of like different infections that are spreading. Because I think one of the feedbacks that they said to us is that people are afraid still to show up to these town halls because of like spread. And so I thought, wouldn't it be nice if they can see what's actually spreading or not spreading, through the dashboards that we can create for them, very easily. And so I think just increasing information, is one way as well to increase awareness and mobilize them to make changes, I guess.
Yeah. So
But thanks for sharing, Kim.
yeah, great points. And